have Dr. Manisha's presentation on, please? This side? Manisha here. And we have a keynote address in the end. I'll request Dr. Sampath to put his laptop there so that after this we can. Thank you, Dr. Lal.
Good morning, everyone, and thank you, Dr. Ajay, for making me a part of this wonderful session on diabetic retinopathy. I think Rajiv has beautifully covered what's going on new in artificial intelligence and DR. However, we need to understand that there is a lot happening even in diagnosing diabetic retinopathy. So, wide field and ultra wide field fundus photographs are very much in use now. And the difference that these wide field images have made, that they've led to classification of greater degrees of DR severity in about 20% of the eyes. So the eyes which were considered to be of lower severity are now thought to be of a much higher severity. The peripheral DR lesions are independently correlated with an increased risk of PDR, and probably these lesions were not caught earlier. As far as the screening of DR outside ophthalmic clinics is concerned, it's primarily focused to telemedicine and also to the use of non-mydriatic fundus cameras with artificial intelligence. The advantages being easier access and better compliance, as these screenings can be done at primary healthcare provider clinics and not necessarily ophthalmic clinics. So here you see this is a small model of how we are going to be doing a DR screening using telemedicine, and the turnaround time could be as short as 1 hour. But if we are going to be using an AI tool, a non-mydriatic fundus camera with an AI, the turnaround time can be as small as 1 minute. So this has made a huge difference today in DR screening. And more recently, artificial intelligence and deep learning may now be able to prospectively predict the incidence and progression of DR, as Rajiv rightly mentioned. So these are the various aspects of artificial intelligence being applied for an earlier and for a better screening of a diabetic retinopathy. Coming to certain imaging techniques like fundus fluorescein angiography, it has played a very important role earlier also, where we want to grade the severity of DR. It's an invasive procedure. However, it's still considered the gold standard for management of DR, and these are the various indications why we perform a fundus fluorescein angiography in a patient of diabetic retinopathy. However, now with a wide field angiogram, it reveals much more than a normal angiogram, and as you can see over here, the ETDRS fields that we used to be earlier capturing is just limited to a very small portion of the fundus, and now we are able to capture far more in the periphery, leading to much more diagnosis of severity of diabetic retinopathy. Here again, you see in a wide field FFA a patient who's already undergone a laser photocoagulation, but because of the wide field wide field FFA, you were able to see that there are extensive capillary non-perfusion areas in the periphery and requiring a much more tightly packed laser photocoagulation. Coming to OCT, now we are talking of various biomarkers which are helping us in better management planning of diabetic macular edema, and these could be an epiretinal membrane, a neurosensory detachment, a drill as you see over here, a droll, a hyperreflective foci, and based on what biomarker you are identifying on the OCT, your management line can also differ. So if you are having a patient with an epiretinal membrane, of course surgical management is going to be your prime management. If you have a patient with NSD, probably you are going to be scoring steroids over anti-VEGFs. If you are seeing a drill, probably the patient is going to be having a poorer visual prognosis. Coming to Octa, it's a non-invasive tool again for both qualitative and quantitative assessment of macula, including macular ischemia. It's non-invasive, so it can be repeated as many number of times as you want. And various features of diabetic retinopathy can be very well identified and picked up on an Octa. The various Octa metrics that we use in a DR patient is vessel density, the area of the FAS, the area of the non-perfusions, and it also helps us to monitor the progression of the DR. So here you see how beautifully this has picked up the neovascularization, which is proliferating into the vitreous phase. And after you've done the laser photocoagulation, there is a good regression of the entire NVE, and it's beautifully picked up on an Octa. Now, what is new? We have been always talking of diagnosing DR when we are clinically seeing the various manifestations of DR. But with newer imaging modalities, we can actually recognize DR at a subclinical stage. And OCTA plays an important role in doing so. It can offer an opportunity to detect it at a in a subclinical stage in a non-invasive way, and this can totally impact our follow-up and the management. So the changes that can be helping us in detecting DR at a subclinical stage could be a decrease in the deep plexus vessel density, the enlargement of the FAS, the decrease in the parafoveal vessel density, both in the superficial and the deep vascular layers, and the impairment of the choriocapillaris flow. And again over here, I just want to show you that the CNP areas are very beautifully picked up. And this is a patient who's not having any clinical evidence of DR, but because you're having the CNP areas, you know that it has started setting in. The future in diagnosis of DR is the integration of these ultra-wide field color fundus photographs, the OCTA, the omic and the other biomarker research, the artificial intelligence, and of course the statistical modeling. And all these put together are going to help us in facilitating a newer DR classification even before we have the visible DR lesions. And these DR lesions are very typically seen on the two-field retinal screenings and can help in personalized care for DR management in future. We have a lot happening in the management of DR as well, like the Lovago Therapeutics is developing a human antibody therapy that not only treats the symptoms of the condition but also has the potential to renew healthy vascular growth, reversing retinal degeneration, and providing hope for the many who do not respond to current medications. We are also having certain eye drops being developed for management of DR and DME, the advent of the genomic-wide analysis, metabolomics, and proteomic profiling for DR, marking a new frontier for future management. And of course, stem cell therapies and genetic interventions are also being tried. So there's a lot happening both in the diagnosis and for the management of DR, and the future holds strong, and I'm sure that the kind of visual prognosis we have in the patients right now is going to totally change in future. So thank you so much.
Thanks a lot, Dr. Manisha. That was